Good afternoon. I'm Dr. Senthil from Anaesthesia Department of Sri Lakshmi Narayana Institute of Medical Science, Pondicherry. Today, my e-topic will be on Pheochromocytoma and anesthetic concerns. Regarding anatomy of adrenal gland. Adrenal gland measures about 5 into 3 into 1 centimeters with a weight of 4 to 5 gram. Right gland is pyramidal, in close proximity to right hemidiaphragm, liver, and inferior vena cava. Left adrenal is closely associated with aorta, spleen, and tail of pancreas. It is divided into cortex and medulla. Cortex forms the major chunk of the gland, which is about 85%, and medulla is only 15%. Largest of the extra-adrenal neuroendocrine tissue is located at the aortic bifurcation or at the inferior mesenteric artery organ and is designated as the organ of Zuckerland. Adrenal medulla tissue may also be found in neck, urinary bladder, and para-aortic regions. Regarding embryology of adrenal gland, the two parts of the adrenal gland, that is cortex and medulla, develop from two different origins. Cortex is mesodermal in origin, develops from the coelomic epithelium of the posterior abdominal wall. While medulla, which is ectodermal in origin, which develops from the neural crest cells. Adrenal gland physiology. Adrenal gland, this is the histological section of the adrenal gland, which is divided into cortex. The entire thing up to zona reticularis is cortex. That is zona glandulosa, zona fasciculata, and zona reticularis. And this one is adrenal medulla. From zona glandulosa, melanocorticoid is secreted, which is aldosterone. From zona fasciculata, glucocorticoid, that is cortisol, corticosterone, and cortisone are secreted. From zona reticularis, androgen is secreted, that is dihydroepiandrosterone. From medulla, stress hormone like epinephrine and norepinephrine are secreted. 10 to 20% of the gland volume is reddish brown in color, and this gland produces epinephrine and norepinephrine. Phenylethanol N-methyl transferase only present in adrenal medulla and organ of Zucker gland. That is why adrenal is synthesized in adrenal medulla alone, and it is converted to norepinephrine to epinephrine. Catecholamines are stored in electron-dense granules. Hormonal secretion is stimulated by a stress stimuli. And this is the synthetic pathway of adrenaline, noradrenaline, that is epinephrine, norepinephrine. Tyrosine is converted by tyrosine hydroxylase enzyme to form L-DOPA. L-DOPA is again decarboxylated by dopa decarboxylase enzyme to form dopamine. Dopamine is converted to norepinephrine, which is again converted to epinephrine. From epinephrine, we get metabolized to form metanephrine, and norepinephrine is metabolized to form normetanephrine. From both metanephrine and normetanephrine, we get vanillyl mandelic acid, which is excreted in urine. Diseases of the adrenal gland. From adrenal cortex, incidentoma, non-functional adenoma, Cushing's adenoma, adenocortical carcinoma, Crohn's disease, myelolipoma, and assistant metastasis occurs in adrenal cortex, while pheochromocytoma and neuroblastoma occurs in adrenal medulla. Regarding pheochromocytoma and endocrine stress mimicking disorder, pheochromocytoma, that means dust-colored tumor. Rule of 10 in relation to pheochromocytoma, that is 10% of the tumor occurs in children, 10% is familial, 10% malignant, and 10% extra-adrenal, 10% bilateral, and 10% recurs, that is recurrent tumor, 10% discovered incidentally, and 10% is calcified. Epidemiology related to pheochromocytoma. Prevalence is about 0.2 to 0.6% in patients with hypertension, and incidence of 0.8 per 1 lakh person year. Less than 0.1 of all cases of hypertension are caused by pheochromocytoma. In adults, 55 to 60% occurs in female, and in children, about 70% occurs in boys. 10% patient part of familial disorder, Menn syndrome, von Hippel-Lindau syndrome, neurofibromatosis type 1, or familial paraganglionoma syndrome. Pathophysiology. A catecholamine producing tumor arising from the chromaffin cells of the adrenal medulla. Paraganglioma are closely related neuroendocrine tumor arising from extraadrenal paraganglioma. Sympathetic paraganglioma, paravertebral ganglion of the thorax, abdomen, and pelvis. Parasympathetic paraganglioma arise from vagal and glossopharyngeal nerve at the base of skull and neck. Regarding the receptors, alpha adrenergic receptor, alpha 1 receptor located at the post synapses of sympathetic nerves, and stimulating alpha 1 receptor, it leads to vasoconstriction, thereby increases the blood pressure, causing hypertension. Alpha 2 receptor, they are located in presynaptic of sympathetic nerves, and it causes feedback inhibition of norepinephrine release, dampens the function of sympathetic nerves. Beta adrenergic nerves, beta 1 receptor increases heart rate contractility and increases renin secretion. Beta 2, it is located in smooth muscles, that is tracheal, bronchial, gallbladder, uterus. Thereby it causes, on stimulation, it causes spasmolysis. Effects of catecholamines. Norepinephrine predominantly acts on alpha and beta 1 adrenoreceptor, thus higher concentration of norepinephrine leads to headache, hypertension, palpitation, sweating. Low and medium concentration of epinephrine acts on beta 2 adrenoreceptor, causing a vasodilatation, thereby leading to hypotension. High concentration of epinephrine acts on alpha adrenoreceptor, which increases systemic vascular resistance, and paroxysmal hypertension occurs. Increased dopamine acts on alpha and beta adrenoreceptor, causing hypertension and tachycardia. Signs and symptoms. Classical triad, that is 3 P's related to pheochromocytoma or pain, that is headache, perception, that is increased sweating, and palpitation, increased heart rate. Hypertension occurs in 90% of the patient, and headache, perspiration, palpitation, pallor, and paroxysm occurs in pheochromocytoma patient. Other non-specific presentation includes anxiety, lethargy, nausea, weight loss, hyperglycemia, tremors. Abdominal pains may result from bowel ischemia due to excessive vasoconstriction. Visual disturbance may develop from papilledema induced by malignant hypertension. Other subtle signs. Paroxysmal hypertension that occurs in 35 to 50%. 30% have sustained hypertension, and 24%, 24 hours ambulatory BP monitoring is mandatory. Orthostatic hypotension also common secondary to hypovolemia, and impaired venous and arterial vasoconstriction reflex response. Though patient is in hypertensive state, there will be a constant state of volume contraction in this patient. Paroxysms or pheochromocytoma crisis. It occurs in 10 to 17% of cases, and it lasts for 10 to 60 minutes duration. Precipitating factors are any activity that displaces the abdominal content or that increases the intra-abdominal pressure. Palpation of abdomen, uterine contraction during labor, defecation, change in posture, micturition. Drugs that can precipitate are tricyclic antidepressant, monoamine oxidase inhibitor, phenothiazines, droperidol, metoclopramide, naloxone. Symptoms due to epinephrine are headache, profuse sweating, palpitation, apprehension, often with a sense of impending doom, pallor, flushing due to peripheral and adrenergic responses. And symptoms due to dopamine are nausea, vomiting due to vasodilation in the gastrointestinal tract. Hypotension. Orthostatic or paroxysmal hypotension can occur in many patients. Mechanism is like extracellular fluid volume contraction, loss of postural reflexes due to prolonged catecholamine stimulation, tumor release of adrenomedulin, vasodilatory and neuropeptide that can also cause vasodilatation and hypotension. Cardiac manifestation in pheochromocytoma. These pheochromocytoma patients can have sinus tachycardia, bradycardia, supraventricular tachycardia, ventricular ectopics, and ventricular tachycardia. Catecholamine induced increased myocardial oxygen consumption and coronary vasospasm. Angina and frank MI can occur in patients with pheochromocytoma. Cardiomyopathy can also occur. Concentric hypertrophy due to elevated blood pressure and sinus nodal dysfunction can occur. Neurological manifestations like hypertensive encephalopathy, stroke due to cerebral infarct or embolus, intracranial bleed can occur. Metabolic symptoms like hypercalcemia, suppression of insulin secretion, glycogenolysis. Epinephrine causes stimulation of insulin release through beta-2 adrenergic receptors. Polyuria can occur and lipolysis can occur, which can lead to weight loss. Indicators of suspicion of pheochromocytoma like family history of multiple endocrine neoplasia or pheochromocytoma, paroxysmal headache, paroxysmal sweating and palpitation, hypertension at an early age that is resistant to therapy, or unexplained grade 3 or grade 4 retinopathy. Orthostatic hypotension in patients who are not on antihypertensive therapy. It can be incidentaloma in adrenal gland. Coronary striate, gastric stromal tumor, pulmonary chondromas, and extra-adrenal paragangliomas can occur. Differential diagnosis for pheochromocytoma that includes hyperthyroidism, cardiac conditions, carcinoid tumors, anxieties, and panic attacks. Diagnosis of pheochromocytoma, non-specific investigations like raised hematocrit due to reduced intravascular volume and hemoconcentration. Hyperglycemia due to ectopic parathyroid related proteins, uncontrolled hyperglycemia, raised blood urea nitrogen, serum creatinine due to myoglobinuric renal failure. ECG findings in an pheochromocytoma case includes left ventricular hypertrophy, left bundle branch block, right bundle branch block with P-wave changes and MI or tachyarrhythmias can also occur. Chest X-ray, there will be cardiomegaly owing to ventricular hypertrophy. Echocardiography may show left ventricular hypertrophy, catecholamine induced cardiomyopathy. Specific investigation for pheochromocytoma that includes biochemical determination of free catecholamine and catecholamine metabolites. 24 hours urine assay includes metanephrine, which is most specific, followed by catecholamine and vanillyl manolic acid. Plasma catecholamines like normetanephrine level greater than 400 picogram per ml or metanephrine level greater than 220 picogram per ml suggestive of pheochromocytoma. Pharmacological tests that may be provocative test or suppression test. Among provocative tests, glucagon provocative test is there, histamine provocative test, and tyramine provocative test is there. Among suppression tests, clonidine and phentolamine suppression tests are there. Clonidine suppression test. Clonidine suppresses normal neurogenically mediated catecholamine release, but does not affect autonomous tumor production of catecholamine. Glucagon stimulation test may precipitate hypertensive crisis. Pheochromocytoma patients will have 3 times increase in plasma norepinephrine with glucagon. Tumor location can be localized using CT scan, MRIs, selective venous catheterization, blood sample taken from vein draining tumor, arteriography, MIBG scintigraphy, PET scan, ultrasonography, IV pylography. Preoperative optimization. For preoperative optimization in patient with pheochromocytoma, we usually follow a Roisen's criteria that includes no in-hospital blood pressure greater than 160/90 millimeters of mercury for past 24 hours period before surgery. No orthostatic hypotension with a blood pressure less than 80/50 millimeters of mercury. No ST or T wave change for past 1 week prior to surgery, or no more than five premature ventricular contractions per minute. Preoperative preparation of pheochromocytoma patient goals are arterial pressure control, reversal of chronic circulating volume depletion, heart rate and arrhythmia control, assessment and optimization of myocardial function, reversal of glucose and electrolyte disturbance. Phenoxybenzamine is used to manage pheochromocytoma, and it is a drug of choice, and it is a non-competitive alpha-1 antagonist with some alpha-2 blocking property, which is started at 10 milligram oral 2 times a day, and it is increased until BP is controlled and no more paroxysm occurs. Drawbacks with this phenoxybenzamine, since it has a prolonged effect on alpha receptor and hence discontinued its use 24 to 48 hours before surgery to avoid vascular unresponsiveness immediately following removal of the tumor. Other drugs that can be used are prazosin, tirazosin, and doxazosin. These are selective alpha-1 blockers, which are short-acting compared to phenoxybenzamine, causes lesser tachycardia, and easy to titrate to desired endpoint than phenoxybenzamine. Doxazosin is an oral dosing starting at 1 milligram, and it is titrated up to 16 milligram if required. Calcium channel blockers can be used. Calcium is triggered for catecholamine release. Calcium is a trigger for catecholamine release from the tumor, and excess calcium enters into myocardial cells, contributes to a catecholamine-mediated cardiomyopathy. So calcium channel blockers like nifedipine and nicardipine can be used. For nifedipine, 30 to 90 milligram dosing per day, and nicardipine 30 milligram BD can be used. Alpha-1 blockers plus calcium channel blockers is an effective combination in treatment of resistant cases. Next drug is regarding beta blockers that is used in treatment of pheochromocytoma. That is used to control reflex tachycardia and prophylaxis against before surgery. Starts only after effective alpha blockade. If suspected the congestive heart failure or dilated cardiomyopathy, start lower doses of beta blockers. Propranolol starting dose is 40 milligram per oral 2 times a day, up to 480 milligrams per day in divided doses. It can be given through IV route also with 1 to 2 milligram bolus doses. Side effects of beta blockers includes cardiac failure and bronchospasm. Atenolol is a selective beta-1. Dosing for atenolol is 50 to 100 milligram per day per oral, maximum up to 300 milligram per day. For IV is 2.5 to 10 milligram per day can be used. Esmolol is selective beta-1 for intraoperative BP control, and a bolus dose of 250 to 500 units per kg per minute can be used. Other drug that can be used was labetalol, which is non-selective beta blocker, as well as an alpha blocker. A dose of 50 to 200 milligram per day per oral, or IV 0.25 milligram per kg. Assessment for optimization of pheochromocytoma patient. This should be started at least 10 to 14 days preoperatively to allow sufficient time for extracellular fluid re-expansion. The aim of optimization is to minimize the physiological impact of catecholamine release. Treatment of hypertensive crisis. For hypertensive crisis management in pheochromocytoma patient, we generally use IV phentolamine, IV sodium hydroproside, IV esmolol, IV labetalol, IV magnesium sulfate. Regarding alpha-methyl paratyrosine, it inhibits the rate-limiting enzyme tyrosine hydroxylase of catecholamine synthetic pathway and may decrease catecholamine production by 50 to 80%. Dose of alpha-methyl paratyrosine is 250 milligram 4 times a day, maximum up to 1 gram 4 times a day can be used. It is especially useful for malignant and inoperable tumors. Side effects includes extrapyramidal side effects, renal or renal stones, galactoria, and crystalluria. Monitoring. Standard ASA monitors are usually used intraoperatively. That includes SpO2 monitoring, end-tidal carbon dioxide monitoring, temperature and urine output monitoring. Invasive blood pressure monitoring is mandatory in pheochromocytoma surgery. CVP line, Swansdown catheter is optional. Arterial blood gas analysis, blood sugar, routine blood sugar you pass me. Regarding monitoring used in intraoperative period during pheochromocytoma surgery or standard ASA monitors are used. SpO2, end-tidal carbon dioxide, temperature and urine output monitoring, invasive blood pressure monitoring through arterial line, and central venous pressure catheter monitoring, Schwann's gun catheter, arterial blood gases, and blood glucose monitoring intraoperatively. That is the hourly blood glucose monitoring intraoperatively. LITCO and PITCO for cardiac output monitoring. Esophageal Doppler in pediatric populations. Pre-medication before surgery or long-acting benzodiazepine like lorazepam or diazepam administered night before the operation. IV midazolam prior to transfer to operating table. Atropine and glycopyrrolate to be omitted due to tachycardia. Opioids like fentanyl is safe in pheochromocytoma patients. Anesthetic techniques like combined regional and general anesthesia is preferred in pheochromocytoma surgery. Although regional anesthesia protects against stress of surgery, it cannot prevent catecholamine surge due to tumor manipulation. Due to extensive sympathetic block produced by regional anesthesia, severe hypertension can occur during tumor removal. Intravenous induction agents like propofol, which is safe in pheochromocytoma patient and is widely used. In hemodynamically deranged and cardiac destabilized patient, etomirate is a drug of choice, especially in volume depleted patients. Ketamine is better avoided due to sympathomimetic effect, since it increases all pressures. Multimodal approach, like use of benzodiazepine along with opioid and IV induction agent is preferred. Attenuation of pressure responses. It is important for laryngoscopy and tracheal intubation. During laryngoscopy, catecholamine level increases in normal patient from 200 to 2000 picogram per ml. In pheochromocytoma, the surge can be from 2000 to 20,000 picogram per ml. To attenuate the pressure responses during laryngoscopy and intubation, 2% lignocaine 1 to 1.5 milligram per kg can be used. The SMOL 50 to 100 microgram per kg per minute can be used. Regarding use of neuromuscular blockers, drug of choice is like vecuronium, which is non-depolarizing muscle relaxant. It doesn't produce autonomic effect, does not cause histamine release, so there is no fear of hypotension, intraoperative hypotension, and it is most commonly used drug. Succinylcholine is better avoided. Secondly, to fasciculation raise in intraabdominal pressure. Atracurium and neoarcurium avoided. Yeah, you Succinylcholine, which is a depolarizing muscle relaxant, is better avoided because of fasciculation rise in intra-abdominal pressure that can lead to surge of catecholamine during intraoperative period. Regarding atracurium and neothurium, it is better avoided due to the fear of histamine release and hypotension intraoperatively. Cisatracurium and docuranium, these are cardiostable drugs with least histamine release and can be an alternative for vecuronium. Among inhalational anesthetic, isoflurane is extensively used as it does not sensitize myocardium to catecholamine. And other alternative will be sevoflurane, used successfully because of its fast onset of action and less pungent odor. It has favorable hemodynamic profile. It is less irritable to the airway and lack of arrhythmogenic potential. Allothane is better avoided because of arrhythmogenic potential. Goals of intraoperative management. Avoid drug-induced catecholamine release. Avoid catecholamine release induced by anesthetic or surgical maneuvers. Minimize hemodynamic responses in tumor handling. Treat episodes of hypotension after tumor devascularization. Rules of intraoperative management. Avoid drug-induced catecholamine release. Avoid catecholamine release induced by anesthetics as well as surgical maneuvers. Minimize hemodynamic response in tumor handling. Treat episodes of hypotension after tumor devascularization. Drugs to be avoided are drugs that increases catecholamine release should be avoided. That includes desflurane, ketamine, pethidine, atracurium, pancuronium, ephedrine, droperidol, metoclopramide. Succinylcholine, even succinylcholine should be avoided. Intraoperative hypotension and hypertension. Hypertension during resection may arise from general sources specific to all operation, positioning, skin incision, intubation, and is usually transient and respond to quick therapy. The catecholamine releases from excessive stores in nerve endings. During tumor manipulation, pressor response occurs, increased plasma levels of epinephrine and norepinephrine that leads to severe hemodynamic instability and a significant reduction in cardiac output and left ventricular systole and diastole dysfunction. Hypotension following tumor vein ligation. Immediate decrease in plasma catecholamine level. Vasodilatation from residual alpha blockade with phenoxybenzamide. Suppression of normal contralateral adrenal gland from excessive catecholamines. Intraoperative fluid and blood loss. Catecholamine-induced myocardial dysfunction and increased anesthetic depth. All of this contribute to hypotension following tumor vein ligation. Management of hypotension includes prevention. Volume expansion should be attained before tumor vein ligation. First line is ringer lactate solution and physiological saline can be used. Secondary treatment modality includes vasopressors and inotropes. Residual alpha adrenergic blockade and downregulation of receptors make patients relatively less responsive to vasopressors. Intraoperative administration of blood salvage products. Post-resection hypertension secondary to catecholamine content of the blood. Decrease in anesthetic depth will also aid in controlling hypotension. Aim for a CVP, that is central venous pressure, should be around 12 centimeters of water. Management of hypertension, sodium nitroprusside, the agent of choice because of its potency and immediate onset of action and shorter duration of action. Phentolamine, a competitive alpha-adrenergic blocker and a direct vasodilator, is effective, although tachyphylaxis and tachycardia are associated with its use. Nitroglycerin is effective, but large doses are often required may cause tachycardia. Labetalol, which is a non-selective both alpha and beta blocker with more of beta blocking property than alpha blocking property, is preferred for predominantly epinephrine secreting tumor. Magnesium sulfate inhibits the release of catecholamine from the adrenal medulla and peripheral nerve terminals, reducing sensitivity of alpha receptors to catecholamines, is a direct vasodilator and is an anti-arrhythmic drug. It increases the depth of anesthesia, is also an option, but this approach may accentuate the hypotension accompanying tumor vein ligation. Dopamine 1 receptor agonist causes peripheral vasodilation in conjugation with increasing renal blood flow. Intravenous drugs to control intraoperative hypertension in a pheochromocytoma surgery. That includes nicardipine, phentolamine, nitroglycerin, nitroprusside, propanolol, esmolol, and labetalol. Regarding surgery, laparoscopic adrenalectomy, if tumor size is less than 8 centimeters, any tumor size greater than 8 centimeters, transabdominal aperture, any tumor of less than 8 centimeters can be laparoscopically removed through transabdominal or retroperitoneal approach. Slow carbon dioxide insufflation should be done to produce pneumoperitoneum. Open procedures are typically reserved for larger masses and extra-adrenal tumors with limited access. Close communication between surgeon and the anesthesiologist allows anticipation of hemodynamic changes during course of surgery. Postoperative management. Postoperative ventilation ICU stay depends upon the hemodynamic stability of the patient postoperatively. Hypoglycemia, postoperative period due to disinhibition of beta cell suppression, increased insulin secretion, thereby produces a resistant hypoglycemia. Glucose supplementation at the end of surgery, it counters the hypoglycemic episodes. Postoperative hypotension, for postoperative hypotension management, IV crystalloids are first line fluids. Perioperative hypotension, surgical, usually produced by surgical bleeding, inadequate fluid resuscitation, or residual anesthesia-induced vasodilatation. Electrolyte and endocrine abnormalities must be ruled out in drowsy and an unresponsive patient. Majority of the patient becomes normotensive following complete tumor resection. Plasma catecholamine levels do not return to normal until 7 to 10 days after surgery because of slow release of stored catecholamine from the peripheral nerves. Hypertension-free 5 years will be around 74%. For 10 years, it will be 45%. Postoperative analgesia is via multimodal approach through epidural analgesia, transverse abdominal spleen block, erector spinal block, non-steroidal anti-inflammatory drugs, and low-dose aspirin. Anesthetic consideration in patient with pheochromocytoma. During preoperative period, the objective of preoperative care includes arterial pressure control, reversal of chronic circulating volume depletion, heart rate and rhythm control, assessment and optimization of myocardial function, reversal of glucose and electrolyte disturbance. During intraoperative period, the anesthetic consideration are severe cardiovascular instability, particularly at induction of anesthesia and tracheal intubation. During pneumoperitoneum, that is during laparoscopic procedures, during tumor handling, following ligation of venous drainage of the tumor, hypoglycemia after tumor removal. Anesthetic consideration during postoperative period includes hypotension, hypoglycemia, somnolence, opioid sensitivity, hypoadrenalism, and left ventricular dysfunctions. Pheochromocytoma and pregnancy. Though it is rare, it occurs in 1 in 54,000 pregnancy. Very high maternal and fetal mortality. Diagnosis with 24 hours urine collection and MRI. No stimulation, no provocation test or no MIBG is indicated during pregnancy. In pregnancy, the optimal time for resection is second trimester before 24 weeks gestation or after delivery. In late trimester patient with lender's recommendation, resection simultaneously with C-section or after delivery. Conclusion. Pheochromocytoma is managed by multidisciplinary medical team of anesthesiologist, surgeon, endocrinologist, and cardiologist. Principles of anesthetic management includes adrenergic blockade pre-op, vigilant intraoperative monitoring and treatment of hyper or hypotension, good post-operative ICU care, antihypertensive for a prolonged period. And these are my references.